I don't think there are many instances where our blood pressure or our adrenaline flows more than when we're dealing with a difficult airway, especially in an emergency or life-threatening situation. And in that setting, whether it's for a benign airway problem or a malignant airway problem, that is when we have to work extremely closely with our anaesthetic colleagues. You want to have an anaesthetic colleague who is familiar with all the ways that we can access the airway. And if it ultimately results in front of neck access, well, so be it. But everything prior to that, and including that, involves extremely close working with anaesthetists. And in that situation, you want someone like Simon, an experienced airway anaesthetist. He's the airway lead in Dundee for NHS Tayside. He works closely with our colleagues for head, neck and laryngology surgery there. He's a member of the Scottish Airway Society and the Difficult Airway Society. So I can't think of anyone better than Simon to tell us a little bit about how we're going to deal with difficult cases in head and neck surgery when the airway becomes an issue. Over to you, Simon. Thank you very much.
Thank you very much, Kim. Hi, everyone. I'm Simon Crawley. I'm an anaesthetist here in Tayside and airway lead. And this is the first time I've spoken at a surgical meeting. And although I have been to the Head and Neck conference in Edinburgh last year and enjoyed it thoroughly, and I've been listening through most of the morning, and it's been really interesting to understand your thinking and your perspective. And I really must agree with what Kishore said when at 11 o'clock, when the artery doesn't run, it's heartbreaking for him and heartbreaking for me as well. So I'm going to start off just, I mean, if this was a face-to-face meeting, I would ask for a show of hands, but I'll ask Jay to put up the first poll just to see how many friends I have out there in terms of anaesthetists, and there's a handful. Oh, there's more than I thought. Brilliant. And just while that's running, I'll just show my obligatory slide 2, which shows that I've gotten quite a lot of kit from medical device companies who I've worked with in R&D, trying to design and improve equipment, and I've received some funding from them. But I'm not going to speak about those during this talk. Airway management is our defining role. It is what we do. We consider ourselves to be experts. Ian Lasso a long time ago said there's one skill above everything else that we are expected to exhibit, and that is to maintain the airway with perfection. And like has been evident through today, complications are inevitable. Anesthesia is often likened to aviation, and I always disagree with that. Airplanes are designed to be flown. Humans are not designed to be anaesthetized, and the thought of having a metal blade and a plastic tube and the soft, friable mucosa of an airway, it's just not designed to be intubated. So there will always be complications. And speaking at a head and neck meeting, it's probably not the place to talk about the trauma of intubation, because you will deal with the trauma, you'll deal with the subglottic stenoses, the maxvac surgeons and the oral surgeons might deal with the broken teeth. But what I will talk about is something that is a bit more alarming, and is airway death. And although incredibly rare, it does happen. If you search enough through the internet, you'll find various things that have gone wrong, and it's very sad indeed. It is rare though, and we think that airway death is about 1 in 180,000. That is more frequent than I used to think it was. And the risk of hypoxic brain damage is about 1 in 150,000, which again is too high. So why, I mean, these headlines, none of these are related to head and neck surgery. this is orthopedics, this is hand surgery, this is plastics, this is rhinology. We know head and neck is a big deal. We know this is a high-risk group. We know this from the NAP4 audit, which although is an old audit now, it's nearly 10 years old, but the learning from it is timeless. For anyone who doesn't know about it, it was a 12-month UK-wide audit involving 309 hospitals, and they looked at airway management rated complications, and those endpoints were death, hypoxic brain damage, unplanned front of neck access, and unplanned admission to intensive care unit. And in those 12 months, there was 184 cases met that primary endpoint. And 16 of those deaths were in anesthesia, ICU, and the emergency department were much higher risk. And the likelihood is that these were significantly underreported, so the numbers were probably greater. So what's special about head and neck? Well, head and neck accounted for more than half of all those, with 72 submissions out of the 133 that happened in anesthesia. So this is a high-risk group, and even higher than that is the 70% that had some degree of airway obstruction. And when the group that was involved in this audit looked through the cases and really tried to dissect what happened, in over a third of cases, they found evidence of poor planning, poor decision-making, or failure of first-choice techniques and first-choice rescue. Since then, there's been a lot of advances that we didn't have around then. We now have much more universal access to epilaryngoscopy. High-flow nasal oxygen is a part of preoperative care. We use it during some of the tubeless field anesthetics. It's quite useful around extubation. And we have Sugammadex, which helps with providing quality reversal. But I think these advances, I think most anesthetists must know that there are limitations, and that although they've made many aspects of airway management easier, sometimes I think that having these to hand gives us a sense of security that really isn't there. And we think we can intubate someone with a laryngoscope when we should probably just be intubating them awake with a bronchoscope. We think high-flow nasal oxygen will stop them from desaturating, although that only works if you have a patent airway. And we think Sugammadex will save our skin from the paralyzed patient, but it only reverses the neuromuscular component. It does not remove the hypnotic component, and therefore will probably not save your bacon in a can't intubate, can't ventilate situation. Head and neck patients are two breeds. There's the planned urgent surgery where we get time to think. We can sit down with Jay and Sam and the excellent surgeons I work with and review scans and chat about it. And then when the time comes, it's easier because we've already anticipated that I'll do this and he'll do that, and that works. Most of the risk comes in those emergent airway obstructions where perhaps it isn't Jay and perhaps it isn't me, and we have no time for scans. It's 3 o'clock in the morning. It might be a more junior team. So increased risk does come. For us, we like our algorithms, we like our guidelines. There is no guideline for the management of the obstructed airway. The FRCA answer is well, ask the surgeons to do an awake tracheostomy. And if Jay could launch pool 2, just about to see how comfortable people are with this, because it's easy for me to say, oh, Jay, just go and do an awake tracheostomy. But we know that surgeons are exposed to this less and less as more of the intensive care doctors are doing percutaneous tracheostomy. So the exposure for ENT trainees coming through is going to be less. So when you put the pressure of that onto a surgeon, it is not an easy undertaking. And I think it's easy for me to say, I think we should do an awake tracheostomy, but that's a big ask, because this is a difficult operation. And it's interesting to see that some people just aren't comfortable, and that's not surprising. And I think moving forward in time, if we ask the same question in 15 years, then that percentage may be greater. There's little guidance on what we should do. there's little consensus to optimal management. Experts can't agree. Some would do an awake intubation, some would do a gas induction, but it's and it probably doesn't really matter. The ethos that we should share with our trainees, and that is probably agreed, is the right time, right place, right person, right kit, so that you're doing it when it needs to be done. You're using holding measures, you're doing the right place, and sometimes that means staying in ED and not going to theatre, and I'll come through that in one of the cases. The right person, and having that person doing something that they are good at. And there's no point an anaesthetist in this situation using a piece of equipment that they've never used before, because their chance of success is low. So familiarity is the key. You must have a plan B, and having an agreed plan, a specific plan for final rescue. And if Jay could launch poll 3, which was just if you are rescuing an airway from such something that was gone from my end, are you going to do a surgical tracheostomy, or are you going to do a surgical cricothyroidotomy, which is probably what we would do. And obviously you guys are do more surgical trachees than you do surgical crics, but there may be a feeling certainly amongst the airway world, that a surgical cricothyrotomy is much faster to do. And it's sort of a 2/3, 1/3 split on that, favouring surgical tracheostomy, and that's probably because that's what you do. You are good at that. I'm going to talk about a couple of cases that might bring out some of the things I've alluded to, and this is a learning case in terms of. Sorry, Jay, could you close that poll? So case 1 was an AS, and these cases aren't mine. I have a misfortune I have a fortunate situation where I haven't experienced death, an airway death. So these cases have come from that before. So there was an ASA3 patient for a panendoscopy for presumed airway tumor, was pretty comfortable at rest, had very mild stridor. And the anaesthetist in question didn't look at scans, didn't look at nasendoscopy picture. Maybe the severity of it wasn't communicated, and may have been put in a false sense of security by how comfortable the patient was. But the more you do these patients who have chronic airway obstruction, you know that the symptoms and the severity of the obstruction don't really match. And because you get retraining of these respiratory muscles, so they will look well, but their airway may well be shocking. So the anaesthetist dealing with this quest obviously didn't have too much concern and put the patient to sleep. And when you put patients to sleep, you kind of in some way burn your bridges. You either have to get them intubated, or you front the neck, or you're waking them up. You have committed to an intervention, and I would have hated to be the person in this field, because they have gone with laryngoscopy and then they've just seen tumor everywhere, and intubation was impossible, mask ventilation was impossible, everything was impossible. And during a rescue tracheostomy, because the patient was hypoxic for such a long period of time, they arrested in theatre, and I think in this case the rescue tracheostomy took at least 15 minutes, which in an emergency situation like this is too slow, which may be a reason for a surgical cricothyroidotomy. And certainly in briefs where we think this may be a possibility, I've recalled on several occasions specifically saying to Jay, and if we need it, you will do a surgical cricothyroidotomy because it's faster. We think all anaesthetists should look at scans and should be good at interpreting CT scans, and they should be able to do a nasendoscopy. In at-risk patients, we should really be reviewing these patients jointly. And if those scans were 6 months ago, 8 months ago, then I think they should be rescoped on the day of surgery to outline where the obstruction is and how bad it is. so that my plan A is still the right thing to do, or perhaps it's not the right thing to do, and then I will change. Learning case 2 and 3 are both about failures of techniques, and we will all fail at some point. This was an ASA3 patient for a transglottic tumor with obstructive symptoms and was attending for a tracheostomy prior to radiotherapy. So I can assume that the degree of obstruction was reasonably severe. Again, despite these, an awake technique was avoided and GA was induced. Intubation failed, LMF failed, mask ventilation failed. In those days, some anaesthetists would have done a needle cricothyrotomy, but that failed as well. The surgeon arrived in and tried to intubate with a bronchoscope, and that failed as well, and the patient succumbed. ASA3 patient following pharyngeal surgery and radiotherapy. Every component of airway management was predicted to be very challenging, but despite this, the anaesthetist has not altered their plan. So they've said things will be difficult, but they've put them to sleep anyway, and things started off okay, but then intubation was difficult, several attempts, increasing swelling, blood secretions, and then having gone from a can ventilate, suddenly became a can't ventilate, and profound hypoxia. And in this case, they were rescued by the surgeon doing a very, very quick surgical tracheostomy. We need to understand that techniques can fail and will fail, even, but the mantra we drill into our junior trainees is that if you keep trying to intubate them, you will eventually make their airway worse, and we our algorithms we work to sort of limit ourselves to 3 attempts and then 1 expert attempt, because repeatedly doing the same thing you will become less likely to succeed. Were you things component may be tricky, then awake techniques are invariably always safer, and certainly in head and neck populations the threshold for having an awake intubation should be much lower. We teach this, we train this, but there's lots of evidence to suggest that there are some times when this is probably the best thing to do, but it is avoided because less familiar anaesthetists decide that they're not particularly skilled in that. Therefore, they'll just do what they normally do, and they'll put the patient to sleep, and then it goes wrong. Case 4, just this is about location. This was a patient in RED a few years ago with severe angioedema, had a nasendoscopy in ED that showed significant upper airway swelling, but you could still see the glottis, and the patient was transferred to the operating theatre for airway management. And this is something I've always been slightly uneasy with, where our exam answer was always, if you have a difficult airway, you go to theatre to sort it out. And I may be in the minority, but I'm a strong believer that exposing yourself to a transfer shouldn't be a default move. It should be considered and risk assessed, and sometimes that sometimes means making the airway management independent of the location, and staying in the ED and dealing with the airway there. This patient was transferred and deteriorated en route, and by the time they got the transfer to the operating theatre, had obstructed completely, was failed to be intubated, front of neck access failed, and they died. And what's really sad about this is that 10 minutes before that, the glottis was visible, and I guess in theory, with hindsight, obviously, that patient was intubatable 10 minutes before. So that mantra of must go to theatre should be challenged, I think. But we are all happier when we're in our operating theatres, because that's where we work all the time. But to some degree, I think we have to overcome that. So right place, we should do complex operations in theatre much better than anaesthetic room, but sometimes moving to theatre should not be the default move. that was my learning from this case, although it wasn't my case. Extubation is dangerous, and it was interesting to hear the last talk where his scariest operation was because of extubation, and there were lots of themes about extubation in the NAPFOR data, and it's airway obstruction, post-obstruction, pulmonary edema, and bleeding, and I think extubation probably gets ignored a little bit in anaesthetic training because it's not as sexy as intubation, and we don't get to use as much equipment and as many toys, but it is so important, and even more so in head and neck surgery. A third of the cases from NAPFOR all occurred at extubation, and it really drives home that need to make an extubation assessment at the time, thinking about and relaying to on-call teams how this particular patient should be re-intubated, and doing more training and safety on advanced extubation maneuvers. Things that we can do, we can use some high flow nasal oxygen in recovery. If the flow of that exceeds the patient's peak inspiratory flow rate, it will reduce the patient's work of breathing. And this is certainly a useful thing with people who have obstruction before they come to theatre. It will make it easier for them to breathe. They will feel less distressed. They will use less energy trying to breathe through their obstruction. It also has some CPAP effects and is as effective as NIV. I think I'm coming close to the end of my time. I've just got two very short things to show that just in terms of how we can control an extubation. This is our remifentanil extubation. This is when the drug remifentanil has impressive laryngeal reflex suppression and cough suppression. So that reduction of cough can be a big deal. There's certainly less hemodynamic surges because we avoid the cough. The patient is tube tolerant. We clear the hypnotic agents, so they are completely awake, as you can see in this guy's video. And then when the patient's ready to wake and open their mouth, they do, and it's really smooth. And when it goes well, it's one of the most satisfying extubations you can ever do. And I know my surgeons appreciate a nice extubation. Yes, it does take a little bit longer, and it eats into a little bit of time, but it is worth it, and it is something we train our trainees here to do. The next one is, and this is the last one, Jay, is the use of an airway exchange catheter, and this is a patient who has a large submandibular abscess, and we've done an awake extubation, but we're concerned about re-intubation and how easy that will be. So we leave a airway exchange catheter in the airway, remove the tube over the catheter, and then leave that in for a few hours whilst we observe the patient into the recovery unit, so that if there is a deterioration in the airway, then we have an easy route back in. This is always better tolerated through the nasal route. It's a bit more challenging with the oral route, but there are ways to make that succeed. And it will invariably make your re-intubation plan slightly easier because you have a track to the airway. So to summarize, head and neck anesthesia is a team sport. It is high risk. We work closely together, as Kim said. We need to communicate. We need to trust each other. We need to speak to each other, and when we're concerned, we need to be open and honest about, I'm worried about this. And Jay will know that almost the first thing I say to him in the morning, I'll ask him if he has any concerns or anything he's worried about. We need to highlight high-risk cases in advance and agree a final step rescue plan right from the start as to whether that's surgical trachea, whether it's surgical cricothyroidotomy, but it has to be clear, because I need to know what you're going to do and you need to know what I expect of you, and it's agreed. For the anaesthetists out there, we need to accept that we will fail. Keep in our minds that repeated attempts just will not help you. And then that ethos, it doesn't matter on the technique, but it's having the right person, right time, right place, and doing something you are good at. Using stuff you are good at using will always be the best outcome. Thank you.